So I work at City of Hope National Medical Center, and while we are an NCI-designated cancer center, it functions for cardiology a lot like various community hospitals where we don't have a cardiac cath lab. In the absence of a cath lab, it's difficult sometimes to get an endomyocardial biopsy to diagnose various diseases, and even our cardiac MRI program is something that is just being initiated at this point. So for that reason, we've had an impetus to develop a very robust echocardiography program. And as my interest has grown in cardiac amyloidosis, I realized, echocardiography really was the cornerstone of diagnosis, but more so at our institution. So we wanted to look at various parameters that we could look at on echo that may be helpful to diagnose the disease earlier, because oftentimes we were finding these patients pretty late in presentation, where it was difficult to improve their outcomes. And so, I think a lot of the energy in cardiology has been focused on evaluation of the structure and function of the left ventricle, both the systolic and diastolic function of the LV, while other chambers of the heart have sort of been overlooked a little bit. And when you think about amyloid protein, what we find is that amyloid is circulating throughout the heart, and so it deposits not just in the left ventricle. When we think about chambers that are smaller, such as the left atrium, it's markedly thinner. And so you would imagine that a much smaller amount of amyloid protein needs to deposit in the left atrium to make it dysfunctional. And so that was the concept behind looking at left atrial strain. We hypothesized that left atrial strain would be reduced in cardiac amyloidosis, but we also wanted to look at even AL patients who don't have cardiac involvement yet. Like, could this be a marker to differentiate them? And so we looked at 50 patients with known cardiac amyloidosis, 50 patients with AL amyloidosis without cardiac involvement, and 50 patients with multiple myeloma, who kind of served as a control group as patients who have monoclonal gammopathy but don't have amyloidosis. And we did find a significant drop in left atrial strain, reservoir strain, conduit, and contractile strain in patients who have known cardiac involvement. We did not see that signal change in patients who had AL without cardiac involvement. And then we looked at a whole host of other parameters, including right ventricular function, both by strain as well as TAP-C and S' velocities. So all these measures of function were markedly reduced in patients who have cardiac amyloidosis. We're continuing to sort of explore different measures in echo in both 2D as well as 3D echo to see if we can diagnose the disease at an earlier time point.